Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am a clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. Brian Anderson. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science. So, if you like the show, please take a second and write a review. It will support chiropractors everywhere. Here is a review I received on the Chiropractic Science website from Robert Moore. He says, I've been in practice over a decade, and I wish I would have discovered this podcast and website earlier. As an evidence-based practitioner, this is an amazing resource. One major point of why I enjoy the presenter and guests so much is they talk about chiropractic research from a non-biased perspective. Well, thank you, Dr. Moore, for listening and sharing your feedback. If you'd like to leave an audio review that I might include on a future episode, I haven't done one of those, but I'd love to. Just connect on Facebook or send me an email. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website by making a donation. All right, on to the podcast. Well, let's get on to the interview with Dr. Brian Anderson. Dr. Brian Anderson, DC, MPH, MS, PhD, is an assistant professor within the Palmer Center for Chiropractic Research at the Palmer College of Chiropractic, where his research is focused on evaluation of non-pharmacological spine care delivery in the U.S. His background includes 15 years of clinical experience as a licensed chiropractic physician in a variety of settings, including private practice, a hospital-based integrative medicine center, and a chiropractic academic teaching clinic. He has also been an educator for the past 15 years, teaching courses at the undergraduate, graduate, and postgraduate level. With a passion to better understand and contribute to conservative spine care research, he enrolled in a PhD program in health sciences in 2015 with a focus on health services research. His dissertation was titled A Secondary Analysis of Insurance Claims Data to Determine the Association Between Provider Type and Treatment Escalation in Musculoskeletal Disorders, which is a topic he continues to investigate currently. After graduating with his PhD in 2019, he joined the faculty at the Palmer Center for Chiropractic Research, where he has participated in a pilot clinical study as a treating clinician, developed relationships with several research collaborators, and made progress towards developing his own research program. Dr. Anderson's research has been presented at many academic conferences, for which he has received several Best Paper awards. He is currently a co-investigator and primary analyst on a R15 grant titled Spinal Manipulative Therapy versus Prescription Drug Therapy for Care of Aged Medicare Beneficiaries with Neck Pain. He was recently awarded a 2-year loan repayment award through the National Center for Complementary and Integrative Health, and also participated in the fall 2022 cohort of the U.S. Bone and Joint Young Investigators Initiative. Dr. Anderson, thanks so much for coming on the Chiropractic Science podcast.
It's my pleasure, Dean. I've been a fan and avid listener of your podcast from the beginning, and it's really an honor to join you today.
Well, that's great. I appreciate you listening. And so we've got a busy schedule, I think, for this conversation. So let's just dive in. And my first question, as you know, then, is tell us how you became interested in becoming a chiropractor.
Yeah, so many of your guests and many people in chiropractic are drawn to the field after having some personal experience with chiropractic treatment that they might have benefited from, or maybe having a chiropractor in the family who exposed them to the field at a young age. And I really had none of these experiences. My high school had an excellent health careers course, and we were able to leave school for half a day and spend some time shadowing different hospital departments, and we sat in on ambulance rides. We had guest speakers come in and talk about different healthcare careers. And my high school happened to be about 30 minutes away from National in Lombard. And one of our trips was to the anatomy lab at National, which was quite an eye-opening experience for a high school kid. And this was really my first exposure to chiropractic or anything to do with chiropractors. So, my plan going into college as an undergrad was to become a physician assistant. And, I spent quite a bit of time shadowing PAs in different settings. And, after some time, I realized this wasn't a good fit for me. And I needed to kind of evaluate what other opportunities there were in healthcare. I knew that my future was in healthcare, but I'm not quite sure what field was best. So, just kind of as a side note, and in hindsight, I believe that I had a kind of an influential experience as a child with our family physician. His name was Gregory White, and he practiced what I would consider holistic medicine really from the very beginning of his career in the 1960s. So I later found out that he was one of the founding members of the La Leche League, and he promoted natural childbirth and allowed fathers in the delivery room before this was really common practice. So I think that somehow influenced my interest in kind of holistic medicine from a young age. So back to my path to chiropractic. My senior year of college, I started investigating different healthcare related career paths, and chiropractic was one of them. So I spent a day visiting the campus at National in Lombard, and it was a student for a day event. And at that time, they were transitioning their curriculum to what was called problem-based learning. And during this tour, we got to sit in on a simulated small group problem-based learning case discussion. And this was just completely fascinating to me, how they went about the process of working through a case with one of the faculty members kind of observing and asking questions. And yeah, I was completely fascinated by this learning style. And I think if I remember back to that day, I probably applied to National before leaving. And this was without ever actually being exposed to chiropractic treatment as a patient. So, this changed after I applied, and I eventually found a local chiropractor and got to know the profession. And I ended up starting the program in 2001. So that's kind of how I got to chiropractic school.
Brian, that's great. Yeah, we definitely all have a different path getting into chiropractic. And most definitely, we have a different path getting into research. So I wonder if you could tell us about your career as a chiropractor in practice. You got into teaching as well, and then how you got into research and the PhD program. I realize this could take a little while, and that's good. So take as much time as you need to go through that.
Yeah, so I've had quite a unique career path after graduating from National in 2004. So I opened a private practice in a large suburban city west of Chicago, which was at that time and continues to be quite saturated with healthcare practitioners and particularly chiropractors. This is a city that is quite health conscious and has a kind of a higher than average mean household income, I would say. So I felt that was a good location to start my career. So I started the solo practice, did all of the behind the scenes work and scheduled patients and treated patients and did accounting, and did basically everything a small business owner does. And in the beginning, in the first few years, in the meantime, shortly after I graduated, one of my mentors at National, and you may remember Dan Richardson, Dean. He taught pretty much all of the pharmacology and nutrition courses while we were there as students. And he was, getting a little bit older and kind of moving towards retirement. And he was looking to decrease his teaching load a little bit. So he asked me to teach one of the intro nutrition courses in the chiropractic program. And this would have been in late 2005. So I had no teaching experience, but I had a passion for nutrition. I did a certified clinical nutritionist program at the later phases of my chiropractic degree. And I did a lot of functional medicine and nutritional work in my private practice. So I took that opportunity and found out I really enjoyed teaching. I was drawn to it, and I seemed to have a good rapport with the students. I was probably one of the youngest faculty members there, adjunct at the time. So this led to kind of increasing opportunities for teaching in different programs. National had just started their master's degree in acupuncture at that time, and there was a whole series of courses in basic sciences that they had no faculty to teach. So they asked me to start teaching a few of these courses, and that very quickly expanded to pretty much a full teaching load at the same time as trying to run a private practice. And around 2006, we had our first daughter. We did have our first daughter in 2006, and I was at that time primary faculty for 2 nutrition courses, and I was teaching 3 or 4 other courses most semesters. So I had, between 5 and 6 courses I was teaching, and I was trying to, balance the all of the activities that are associated with running a practice. And I had a massage therapist at that point, and I had a couple of independent contractors. So, practice was doing well, teaching was going very well. I was kind of at a point, a fork in the road, so to speak, where I had to choose a path. I couldn't continue doing both full time, basically, while also making time for our kind of new and growing family. So time management was really becoming an issue. So in addition to all of those things I was doing, I decided that would be a good time to start a master's degree in public health.
Why
2006?
Why not just add another thing to the list?
Yeah.
I get it.
I wasn't thinking very clearly at that point, and I'm sure my wife was not on board with any of this, but she's just been incredibly supportive. She's a teacher, and she supported us financially through my chiropractic program. And, I kept convincing her that, okay, this is going to be my last degree program, I promise. And that turned out not to be the case at all. But so in 2006, I started the MPH. And this was before there was much online learning. A lot of the MPH programs now are at least partially or fully online. So I actually had to go and sit in class quite a few nights a week, in addition to doing all the teaching and running a practice. So there came a point around 2008 when I finished my MPH that I had to really decide how to move forward. And the decision I made at that point was to sell my practice to one of my independent contractors. So I did that and just continued teaching pretty much full time. I didn't have a full faculty appointment. I was still an adjunct at National at that point, but I had a full teaching load. Um, an opportunity came available just kind of by happenstance. It is one of those situations where it was a friend of a friend type of situation, and there was an opportunity to work in a integrated medicine center at Northwestern Hospital, which is now called the Osher Center for Integrative Medicine. At the time that I joined, it was called the Center for Integrative Health, I believe. Anyways, it was owned and operated by Northwestern Hospital, and it was in downtown Chicago. And after a very lengthy interview process, I was hired for that position in early 2009. And this was around the time when we were starting to think about, growing our family, having another child, which happened in 2010. And living in the Chicago suburbs and commuting into Chicago was a real struggle. Again, time management wise. I also continued to teach 1 to 2 courses at National after I took this position at the Osher Center. So I was commuting round trip about 3 hours a day to my job downtown. We had our second daughter. I was continuing to teach, burning the candle at both ends, and my wife being very, very supportive up until this point. She was basically trying to raise 2 young kids with me being gone pretty much all day, every day. So I was at that point looking for other opportunities. And in 2011, I had the opportunity to go back and join the faculty at National as a supervising clinician and work in the clinic there, supervising interns starting their chiropractic internship during the last year. And a bonus opportunity that came along with that job was to work alongside the clinician that supervised me during my internship. So shout out to Terry Ranke. If you're hopefully will listen to this at some point.
Hey, Brian,
yes.
Terry was my clinician as well. She's awesome.
Gosh,
she's awesome.
That's so cool. Yeah, she's been there forever, and I think has had some impact on most interns who've gone through that program. So that's great. So anyways, I continue to keep in touch with her to this day, but I got to work there alongside her from 2011 to 2019, really. But kind of going back to the timeline here. So after I joined the faculty, I continued teaching classroom and online courses in addition to my clinic duties. National started a kind of a unique master's degree program at that point. It was called the Masters of Science in Advanced Clinical Practice. And this was obviously a chiropractic specific academic program that was 1 weekend a month for 2 years. And each weekend was, targeted a particular specialty or topic within chiropractic practice. And we had, the top researchers and practitioners in each of those fields and each of those specialties come and teach the weekends. And it was really an excellent experience. So that was my second master's degree after graduating National. So at the end of that program, we actually had to complete a case report. And that was really kind of a unique change. It was kind of a career-changing experience for me because I had previous to that never published anything, and read a lot of research. For when you teach, you end up having to read a lot of research, so you stay up on what's new and exciting in the field. But that was the first time I actually had to sit down and write from beginning to end a case report, which was a great experience for me. And I ended up writing a few more case reports along the way at my time at National. And for most of them, I included interns, who were involved in treating these unique patients that we wrote up. So pretty much this whole time, after I finished the master's in advanced clinical practice in 2014, I was searching high and low for a PhD program that would allow me to continue working. I wasn't in a position financially to quit my job and go off and do a PhD program full time. I have already mentioned my supportive wife several times. This was too much to ask from her. So, I kind of just waited and hoped that I would find something that would fit my schedule and allow me to, fulfill a kind of a lifelong or a career-long dream of finishing a PhD program. And this opportunity came along in 2015. I was actually the first cohort of students in this health sciences PhD program at Northern Illinois University, which was designed specifically for mid-career healthcare professionals. And it allowed us to continue to work. We did, intensive sessions at the beginning of every semester, and then we did live classes every week online, so synchronous. And it was, a great experience. It was a much different PhD experience than I think most people have when they're, full-time and can dedicate their entire effort to a PhD. But it did allow me to continue working and gain a lot of really practical knowledge on research methodologies, and eventually ended up writing a dissertation. Graduated in 2019, and at that point, I was looking to kind of transition out of the position I was in as a clinician and use all of these new skills that I developed in the PhD program to start contributing as a researcher to the field of chiropractic. So that kind of brings us to 2019 after my PhD graduation. So I'll stop talking and let you jump in.
Yeah. So all of that is fascinating. I think, a lot of the people that listen to the podcast are students as well as docs in the field. So I'm excited that they're going to get all this information to give them sort of, a roadmap, at least, what you went through. And so hearing from multiple people on the podcast, for example, just how they got into a PhD program, how they got interested in, subsequently working in the field in research, I think is just super fascinating. So I appreciate you going through that because the details matter. And so anyways, I think people are really going to enjoy listening to that. So, but I do want to ask you, now we're up to your PhD graduation. You join the Palmer Center for Chiropractic Research. So at this point, maybe you can tell us a little bit about some of your grant writing experience. I know that's something that you want to talk about, as well as just being an early career researcher and possibly some other mentoring opportunities that have come about.
Yeah, definitely. So, when I took this position at Palmer, it's a fully funded position. So, we are not dependent on grant money necessarily, but it is expected that people who are full-time researchers do write grants and apply for grant money to offset their salaries, because most full-time faculty members at universities are paid through their teaching efforts, right? And I don't have any teaching requirements and I don't have any clinic requirements. So my job is 100% focused on research. So one of the first projects that I was involved with when I started here was a pilot clinical trial that Dr. Rob Vining had started, which was called thoracolumbar fascia mobility. And this was really a fascinating project, and I was a clinician on this project. We treated patients twice a week for 8 weeks and used diagnostic ultrasound to look at the mobility of the thoracolumbar fascia at various points throughout the study. So I won't talk much more about that study, but I will send you a link, Dean, to a paper that was recently published, and you can put that in the show notes if other people are interested in reading about it.
Great.
Yeah, so I at the same time started kind of developing my own research program, which was a continuation really of the work that I did in my dissertation. So my dissertation was evaluating healthcare utilization in patients with back and neck or musculoskeletal related diagnoses, and what impact different provider types had on utilization of various healthcare services. So that interest kind of continued as I joined the faculty here, and I started kind of trying to pull papers out of my dissertation, individual papers, and started writing, based on the dissertation project. So the first paper that I wrote up and published is one that we'll talk about here in a few minutes, related to cervical spine diagnoses and patients who receive spinal manipulation versus other types of care, and how that influenced exposure to escalated care or treatment escalation. So I published a few papers on that topic, and I developed some really critical and fruitful relationships with different researchers, just again by being curious about what they were doing and reaching out to them, asking questions about their research. And that ended up with a couple of co-authorships on papers that we'll also be discussing here in a few minutes. So that was, a very crucial turning point for me, is starting to develop these mentoring opportunities with more experienced researchers. And one of the main grant mechanisms that are associated with early career researchers is the K series, and these are all what are called mentored, patient-oriented, or they don't necessarily require patient care, patient-oriented career development awards. So I applied in my first year here to a K23 award, which is, it requires the development of a mentorship team and a training program. So we came up with a series of courses that I would take to kind of fill some gaps in my knowledge on specific techniques. And we have this mentorship team that kind of would guide me along the way. And the project was kind of a unique one, where I was interested in looking at patients who visit the emergency department for low back pain as their initial point of entry, meaning they have had no prior experience with the healthcare system for back pain, and their first ever visit for back pain related complaint was in the ER. So I wanted to see, number one, what happened, what kind of care did they receive within the ER, and then I wanted to follow them for a year and see what types of care they received over time, based on that kind of unique initial care exposure in the ER. And we would use a large nationally representative insurance claims data set to accomplish this. So this was a 6-month process to write this grant, and we submitted it. And basically, you wait 9 months for it to get reviewed, and unfortunately, it didn't get funded, which is the case for most grant awards, right? For most grant applications. I think if you look at overall all NIH funding mechanisms, the success rate is somewhere around 15 to 20% of applicants get funded. So I didn't expect necessarily to get funded my first try, but it was really a great learning experience to write this grant. And we decided that there were a lot of methods and kind of modifications that we needed to make to that application. So we put that on hold as far as a resubmission, because at that point I got an opportunity, just based on, again, developing these collaborative relationships along the way, to be a co-investigator on an R15 grant mechanism. So an R15 is kind of unique because it requires the involvement of student researchers. So R15s generally are only awarded to institutions that don't have a lot of NIH funding. So they're usually smaller private institutions. And Palmer actually had an R15 a few years back when I first started. And my co-investigator on this application is Dr. James Whedon at Southern California University. And we proposed to look at spinal manipulative therapy versus prescription drug therapy in the care of aged Medicare beneficiaries with neck pain. So we submitted this grant, again, quite a long time ago. It was looking good. It got scored very well. And we ended up getting notification just a few months ago that it was awarded. So that was very exciting.
Awesome.
And,
awesome.
Yeah. So this is a collaborative grant. So it's a the primary investigator, Jim Whedon, is at Southern California. So him and his team are going to have 2 students working with them. And then we have a team of researchers here at Palmer, led by myself. And we're going to have a few students working with us here as well. So this is a very unique opportunity to have this distance, geographically distanced collaboration on a large grant project like this. And I'm very excited to get this started. We're now in the planning phase, and we're planning really to kick this off as far as data analysis starting in January. So we have a lot of the program kind of developed already, and we're starting to have regular meetings. So that was funded, and that's a 2-year award. So I am I'm funded at 20% effort on that award, which means that 20% of my if my full effort is 100%, and I have a full-time research position, this grant pays for 20% of my effort. So it's not a full-time coverage, but it's a good starting point for a first grant award. And I get to also work on other projects at the same time. So simultaneous to kind of this R15 and K23 applications, I applied for an NIH loan repayment award. And so this award requires that you do have a substantial amount of your effort dedicated to research. And it offers a certain amount of money per year that the NIH will pay off for your student loans. And it's a 2-year award, and it is renewable. So I applied for that quite a while back, and found out a few months ago again that I was awarded that the NIH, the loan repayment award, which is very
Congrats.
exciting. Yeah, very exciting, because I directly benefit financially from this award. The money doesn't go to me, but it essentially goes in my pocket, because it would have been money that I would have been paying towards my loans. So the NIH pays the loans directly. They also pay the taxes that would be associated with having an award like this. And I decided, because this is such an important program and more people need to know about it, that I signed up to be a loan repayment program ambassador, which means that I kind of act as a liaison for people like me who apply to this program, to provide information and experience and best practices on how to develop one of these applications, and how to be successful, or improve your chances of success. So if I mentioned earlier that most of these NIH awards, the success rate is around 15 to 20%. The loan repayment program is closer to 40 to 50% success rate if you qualify, right? That's the catch, is you do have to qualify based on the type of position you have, and which does require a certain amount of effort towards research. So the last kind of opportunity here that I'll discuss in that realm is the U.S. Bone and Joint Young Investigators Initiative. So this is a program that has been ongoing for decades, really since 2000. This used to be called the U.S. Bone and Joint Decade, so some might recognize that name. And in 2000, they transitioned to the U.S. Bone and Joint Initiative. And they have now a Young Investigators Initiative, where you apply and they accept a small percentage of those applicants, and they have these workshops where you come and get mentorship and you get education on best practices for writing grants. That's really what they're focused on, is getting young investigators successfully funded to do research that is important to them. So I was accepted in this program, and I attended the first workshop last month, actually. It was in Chicago, and it was a tremendous experience. You get connected with two mentors that have kind of research interests that are along the lines of mine, and they provide kind of one-on-one mentorship in addition to the larger group. And there is a follow-up workshop once you have developed kind of what you consider to be a complete grant application. And prior to submitting it, you go to the follow-up session, and you have this grant application completely reviewed. They have mock review panels there, just like they would in NIH study sections. And they critique it, and they help you make it better to improve the likelihood that you're going to successfully get funded. So this is a great opportunity, for people who are in early stages of their career to get mentorship, specifically on grant writing. So yeah, I think that's a pretty good summary of all of the different types of grants that I've kind of looked into and applied for, and the different mentorship opportunities. So yeah, I'll send it back to you, Dean, and see where you want to go from there.
Yeah. So like I say, I think this will be sort of a compendium for people who are interested in pursuing the PhD and then ultimately, knowing what to do in terms of grant writing, et cetera, afterwards. A lot of good nuggets there for listeners who are interested in doing this kind of work for sure. So I really appreciate you going through that. I do want to talk about these papers that you have published. I think they're fascinating papers. So why don't we get started with them? And the first one, and you'd mentioned this already, is called Risk of Treatment Escalation in Recipients versus Non-Recipients of Spinal Manipulation for Musculoskeletal Cervical Spine Disorders and Analysis of Insurance Claims. And this was published in JMP in 2021. So I wonder if you could just tell us about that study, and then maybe I'll ask you a question or two about it after.
Sure. Yeah, I'd be happy to. So this is one of the first papers that I pulled out of my dissertation. And so the purpose really of this study was to evaluate the relationship between treatment escalation and spinal manipulation in a cohort of patients with cervical spine diagnoses. So there's no real standardized definition of treatment escalation in the musculoskeletal realm. It's used in a lot of other aspects of healthcare. But in this paper, we define treatment escalation as interventions, the presence of interventions such as imaging, injection procedures, emergency room visits, or surgical procedures. So we used a large insurance claims data set from a single Fortune 500 company. And again, we wanted to evaluate what happens when patients with neck pain are either exposed or not exposed to spinal manipulation, and how does that impact their downstream exposure to all of these escalated care procedures. So we used some regression modeling to look at that kind of association, and you account for a number of other covariates, sex and age and risk score, and a variety of other variables. So the bottom line here is that in patients with neck pain who receive spinal manipulation versus who don't, have a much lower risk of escalated spine care. So we actually, in the model, we evaluated those patients who did not receive spinal manipulation. So we found that the risk of treatment escalation was 2.38 times higher in those patients who were non-recipients of spinal manipulation, meaning they received any care other than spinal manipulation for neck pain. So when we say that they had a 2.38 times higher risk of treatment escalation, that includes exposure to any of those interventions that I mentioned earlier: imaging, injection, ER, surgery. So we evaluated each of those interventions individually and then as a group. So the 2.38 relative risk is related to all of those interventions grouped together. So that was, I think, a very important finding, related to the protective effect that spinal manipulation has against treatment escalation.
Yeah, I think that's really fascinating stuff. I get the sense of, just being a chiropractor in practice, that's what seems to happen in practice. But it's nice to see research being done by yourself looking at this. So I think it's super practical from not only an individual person's practice, but also, and more importantly, the entire system, I think. And, we may not be able to apply this across countrywide necessarily, but I think the results are super intriguing. I did want to ask you something. Now that you're going through it, you mentioned the 2.38 times higher estimated risk. Was there one, and I guess I didn't look closely enough in the paper, but was there one that was particularly like highest, or were they all kind of clustered around that 2.38?
Yes. So the escalated intervention that was associated with the highest relative risk was emergency department. So those patients who were in the non-SMT group had nearly a 17 times higher relative risk of having an ER visit for neck pain than the SMT group.
Wow.
So that's quite
huge,
right? Yeah.
Yeah.
So I've thought about that a lot, and there's other papers that actually contradict that finding and find that chiropractic patients are more likely to have ER visits for whatever diagnosis they're being treated for. But I found consistently in at least in the data set that I'm using, that spinal manipulation is very much protective against patients going to the ER for whatever diagnosis they're being treated for by the chiropractor. And one thought on that is patients generally go to the ER because they're scared that something is very much wrong with them, right?
Right.
Like they have maybe a fracture or an infection, or they have cancer, or like this can't just be back pain or neck pain because the pain is just too much. So what chiropractors do a really good job with is a thorough evaluation and spending time educating patients on what are these red flags that we're looking for, and the fact that a great majority of patients don't have any of them, right? Mm-hmm. And it's basically reassurance that we do a really good job with. And we do that well at the initial visit, but we also see patients relatively frequently. And there's kind of this constant reassurance that assuming we're doing our job correctly and evaluating patients appropriately, that we can rule out all of these reasons why patients would go to the ER in the first place. And we can educate patients about conservative care is appropriate for a vast majority of patients. And there is nothing concerning here that would lead me to believe that you have any urgent need to be evaluated in the ER, right?
Right.
So patients who visit other types of practitioners maybe don't get that same reassurance and education, and they're more likely to go to the ER because they just don't know what's happening, and they're afraid, and they feel like they need immediate answers, and that's where you get them, is in the ER. So
gotcha. Yeah, I wanted to ask maybe a couple of other questions. So your paper didn't specifically look at the safety of chiropractic care, obviously, for neck pain. It was looking at the insurance data. However, it is interesting that the data also show that it seems to that people who have gone to a chiropractor, they seem to have a reduced exposure, we'll say, to some of these other things like injections that do carry higher risk. And so I wonder if you could just maybe talk about that, what your thoughts on that might be.
Yeah, so you're right that we can't insinuate or conclude anything about the safety of chiropractic based on insurance claims. But the fact that we can influence exposures to a lot of these invasive treatments, and in this particular paper, We didn't look at opioids, but in other papers that I've published, we have looked at opioids. And there's a lot of risk factors associated with opioids as far as, overdose and dependence. But as far as, safety of procedures themselves, there are risks associated with surgery, significant risks, and, interventional procedures like injections. So, if we can keep patients away from those interventions when appropriate, right? There are situations when those interventions might be appropriate, but for the most part, patients do well with conservative care, and the safety profile of chiropractic care is, about as good as you can get when you compare it to all of these other escalated care interventions. Even if you're considering something like imaging studies, there's lots of research looking at early exposure to imaging studies has serious downstream consequences regarding exposure to other types of interventions and prognosis, right? So I think the more we can prevent these exposures, we improve the safety profile of treatment globally. At least that's my interpretation of these results.
Sure, absolutely, agreed. So I'm here in Ohio. I'm pretty active in our state association here. I'm just wondering, what can a chiropractor in practice do with this information? Just trying to think of, sort of a knowledge gap thing. Obviously, I think the profession as a whole is trying to get this information out to legislators and whatnot. And I'm sure you've thought of these kind of things. I'm just curious to get what your opinion might be.
Yeah. So, I guess I don't have great advice for individual private practitioners. However, state associations are made up of private practitioners, right? And these associations have some influence on policymaking at the state and federal level. So, ultimately, the goal of the research that I'm doing is that we would like policymakers and payers to somehow incentivize providers that are practicing guideline concordant care and safe care, and encourage insured members to initiate care with these types of providers, right? And so really what I envision if we're talking big picture here, is spine care pathways in every large healthcare system where we have a portal of entry provider that is a conservative practitioner, right? Like a chiropractor or physical therapist, for example, and potentially having a medical doctor on staff for those cases that need it. And this is really practicing evidence-based spine care is based on the results that I'm seeing from our research. We want to initiate care with conservative management. And the types of practitioners that are most likely to provide evidence-based conservative management are chiropractors and physical therapists. So, I'll talk more about this issue when we cover the papers on Medicare data, because I think I have more to say about Medicare specifically. But as far as private insurance, we need to somehow have incentives for patients to seek care from conservative care practitioners, and that these practitioners are somehow incentivized to when they keep patients out of unnecessary escalated care situations.
Yeah, perfect. I mean, it just makes total sense. For sure. Well, you mentioned the paper about Medicare, so let's dive into let's dive into that. So the effect of the next paper, the effect of reduced access to chiropractic care on medical service use for spine conditions among older adults. Also published in JMPT. I think it's the same issue actually as the other one.
Yes.
Okay, great.
That was a good month.
You were on fire. That's awesome. So let's go ahead and if you could walk us through this paper.
Sure. So this is one of those collaborations that happened by just reaching out to an author of a paper that I had a question about. And this is Matt Davis and his group at University of Michigan. Matt's a DC PhD, health services researcher, and he had an R01, which is, the primary kind of gold standard NIH research grant. And the goal of that R01 project was to look at patients, Medicare patients, who move geographically from one hospital region to another. And they evaluated the practitioner to population ratio of a variety of different practitioners. So chiropractors, primary care doctors, and surgeons. And they wanted to see what happened when Medicare patients move from a geographic area or move to a geographic area that has a lower availability of chiropractors. So what happens to their visits to other types of practitioners when essentially you decrease the availability of chiropractic care, right? So these are all Medicare patients who, prior to moving, had some exposure to chiropractic. And then they moved and they had less availability of chiropractic. So we wanted to see what happened to those patients, right? Do they continue to seek out chiropractic even though it's less available, or do they transition to other types of care? And what we found is that for every time that a Medicare patient moves to an area with a lower concentration of chiropractors, their rate of visits to primary care doctors increases by 32 visits annually, and the number of spine surgeries increases by 5.5 annually. So this is per 1,000 Medicare insured, by the way, right? So 32 primary care visits per 1,000 Medicare insured and 5.5 surgeries per 1,000 Medicare insured. When we lower the concentration of chiropractic availability, and they looked at quintiles of availability based on practitioner to population ratios. So the results are quite striking here, and the costs are quite striking. So I think you had a question about the cost. So maybe if you wanted to get into that.
Yeah, for sure. So well, as I was going through it, I was just trying to ponder all these numbers that were being extrapolated here from the sample to Medicare as a whole, and it sounds like that this reduced access to chiropractic care would result in an additional 110 million visits to primary care physicians at an annual cost of $27.5 million, and then an additional 19,000 additional spine surgeries at an annual cost of $363.4 million.
Yes.
Those are just astronomical numbers to me. And so I was going to ask you how significant this was to you looking at this data all the time. But the other thing I wanted to just point out, and now it strikes me more clear than ever, kind of, we're having this conversation now, it strikes me that this is kind of similar to the previous paper, right? I mean, this is probably similar in your mind all the way along, but to me now I'm just thinking, well, yeah, this is, maybe preventing some of these other risk factors that we just talked about, but here it's in a different population.
Right. So there's I think this theme to all of the research that I'm interested in doing, which is availability, exposure to chiropractic, and the healthcare utilization consequences of either exposure or non-exposure. So you're right. You picked up on the theme. So good job. Yeah. So the costs that you mentioned are obviously substantial, right? But in the intro section to this paper, we mentioned that Medicare currently spends nearly $30 billion per year on back and neck pain, right? So the numbers that we're referring to here are 27 million, 363 million. It seems like a drop in the bucket when we're looking at big picture of 30 billion per year. But if you consider the year over year accumulation of these costs, adding $400 million per year, which is what we found, based on these numbers, adding an additional 400 million per year to the already existing 30 billion per year, eventually is going to break Medicare, right? There's not an endless pool of money that Medicare has available, and spine care is actually one of their largest spending categories. So Medicare is doing everything they can to try to look at how they can cut costs for spine spending, and all of the results from these studies, as well as many others in this area, suggest that chiropractic exposure is definitely a cost-saving measure, but there continues to be resistance on the part of Medicare to make chiropractic fully available to its fullest scope. And after we talk about the next study, I'll have more to say about that. But yeah, it's substantial and it's unsustainable, and something has to change in the Medicare system in order to intervene on these escalating costs.
Yeah, I'm thinking about just stories that I've heard and some previous patients. All the some people, they have a surgery, of course. Let's say a minority of, I would just say at the outset of this, a minority of people will account for the vast majority of the costs, to my understanding. So let's say you have somebody who has a surgery. Okay, well, perhaps that could have been avoided if they saw a chiropractor. I'm just hypothetically. And that one person who's now had a surgery, maybe they have many other surgeries, after the fact, or they're taking a bunch of medications or injections that possibly could have been prevented by seeing a conservative spine care provider like a chiropractor. So that's kind of where my headspace went when you were talking about the ramifications.
Exactly, and especially if we're talking about older Medicare populations, the majority of their diagnoses are related to degenerative conditions, right? And spine surgeries for degenerative conditions are have particularly poor outcomes. The types of spine surgery that we think about that is successful in maybe a minority or moderate amount of cases is discogenic type of pain, large disc herniations creating neurologic compromise, and that's not the type of conditions we see in Medicare populations. So,
gotcha.
Anyways,
I also wanted to ask you about opioids in this particular study. I think there was a mention that opioid reduction wasn't significant in this particular study. Right. And I wanted to ask you, given the many other studies even those by Dr. Whedon himself
Yes,
have indicated that there seems to be an opioid reduction with chiropractic care. So I just wondered if you could maybe mention or hypothesize why that was not the case.
So I guess just to clarify the methodology here in this study was to look at patients who the result of their geographic move was a decreased availability of chiropractic care, right? So they had less exposure to chiropractic when they moved. So if anything, we would expect that the opioid medications would increase because they're not seeing chiropractic as frequently because geographically there are fewer when they move to these new regions, right?
Got it.
So they're seeing more primary care docs and more surgeons. So if you look at the table of results here, it does indicate that after these patients move into a region where there are fewer chiropractors, the number of opioid prescriptions increases, but it didn't turn out to be statistically significant. So just to give you numbers here, before these patients moved, the rate of opioid prescriptions was 766 per 1,000. And after they moved, it was 1,112 per 1,000. So this is the trend that I would expect to see when you have decreased access to chiropractic care, right?
Got it.
But that association was not statistically significant. So that's why it wasn't reported. Yeah.
Got it. Yeah, I appreciate you clearing that up. I just, it was one of the things I caught, and I not being into the design like you are, I just kind of triggered a question for me. So I appreciate you going through that. So let's talk about another paper, the relationship between healthcare provider availability and conservative versus non-conservative treatment for back pain. And this is also, again, amongst older adults, older Americans. So if you could walk us through this study, that'd be great.
Sure. So this is the same group and the same methods that we used in the previous paper that we just discussed. Same data set. So instead of looking at exposure to surgery and primary care doctors, we looked at a group of services which are conservative and non-conservative in nature. So when patients move, again, from one geographic region to another, and they have either more or less opportunity to see different types of practitioners based on the practitioner to population ratio. So the outcome of interest in this paper was the number of conservative care episodes, which we defined as chiropractic, physical therapy, occupational therapy, or nonsteroidal anti-inflammatory drugs, versus non-conservative, which we classified as imaging, opioids, or spine surgery. So the number of episodes that occurred in each of those categories when patients move from one region to another and the availability of the providers changes. So what we found was that if you, again, you geographically move and there is an increase in one spine surgeon in this new population, this led to 31 additional non-conservative episodes per 1,000 Medicare individuals, which means, again, 31 episodes that were managed primarily using imaging, opioids, or spine surgery. So again, we have, basically we're talking about treatment escalation, right? So if we increase the number of spine surgeons, we see greater escalated care. That's not very surprising.
No, but interesting to get the numbers.
Right. So on the other hand, if we increase the number of chiropractors by one, we see an increase in the number of conservative episodes by 18.7 per thousand. So again, this is fairly intuitive that if there are more conservative care providers, we would expect to see more conservative care episodes. But in addition to that, we see a decrease in 3.3 per thousand non-conservative episodes. So same theme here, right? Which is that these conservative care practitioners decrease the likelihood of treatment escalation, because these non-conservative episodes are involving imaging, opioids, and surgery. So adding one chiropractor increases conservative episodes by about 19, and it decreases non-conservative episodes by about 3. And then we also evaluated primary care doctors. So if we increase the number of primary care doctors by 1 in this new population, then we decrease the number of conservative care episodes by about 2.5 per thousand.
Wow. Well, this gets back to, I guess, our first article where we were talking about, what to do with this information. And from your discussion section in this paper, I'm just going to read this and then get your thoughts on it. You say, despite the inherent limitations, we believe these results further highlight the need for healthcare policymakers to consider how the composition of the workforce affects care. So just maybe we can just have a little bit of a continuation of what we started before and followed up now that we have some more data here.
Yes. So unfortunately, many conservative care providers, and I guess I should speak specifically to chiropractic because that's what I'm most familiar with. Chiropractors are choosing to be out of network with Medicare because of the poor reimbursement and because of the limitations on scope of practice. So as it stands currently, Medicare does not pay chiropractors to conduct an evaluation of their patients, which is standard of care and completely necessary. The only thing that Medicare pays for is spinal manipulation, which is a problem, right? Because their level of reimbursement is quite low compared to most of the private insurers. And the fact that they're not allowing reimbursement for standard of care and things that are within our scope of practice is a reason why many conservative practitioners choose not to participate in Medicare. So what we saw in this study that we just went through is that of the conservative care options, chiropractic, PT, OT, NSAIDs, chiropractic was by far the most utilized conservative care intervention. So if the patients were using conservative care, 71% of them were using chiropractic, okay? So in my opinion, updating Medicare policies to reflect the benefits that we see in studies like we just discussed in older populations may encourage more conservative care providers to participate in Medicare. And based on the results we just discussed as well, the availability of chiropractic plays a huge role in the type of treatment that spine care patients get, whether it's conservative or non-conservative, or the likelihood of progressing to things like spine surgery can be avoided if we have the availability of conservative care providers. It's the state of Medicare policy right now is restricting conservative care providers from participation because of the limits that they place on scope of practice and reimbursement. So that's my soapbox on Medicare.
Well, totally. And I'll just follow it up by just reflecting on some of the current literature we've talked about today, but just bringing in perhaps some others. These studies that have shown a reduction in opioid use and imaging and surgeries. I mean, that's the kind of data it sounds like the legislators and overarching healthcare system wants and needs. And here we are with a track record, being the largest conservative care provider, as you put it. Yes. It seems like we're right there. What is the issue? I really don't understand. Yeah. And the other thing reflecting on it too is the way you put it, I think was awesome. You know, you spelled it out with the Medicare, and it makes me think, okay, and we still have so many people coming to see us as chiropractors, and they're willing to pay out of pocket for their exams, for their adjunctive therapies, because as you said, the only thing that's covered is a spinal manipulation or an adjustment. So, you know, it does make me reflect on, wow, this is it's pretty incredible stuff we have here. I just wish the rest of the world knew about it.
Yeah. Medicare patients want the type of treatment that we offer, and Medicare is not allowing them to receive it, which is really a tragedy. So.
Yep. Okay, so last paper, entitled 3 Patterns of Spinal Manipulative Therapy for Back Pain and Their Association with Imaging Studies, Injection Procedures, and Surgery, a cohort study of insurance claims. This is published in JMPT. Again, if you could walk us through, and then we can reflect on the study as well.
Sure. So this is another study that was pulled in part from my dissertation. It's using the same data set that was used in the cervical spine study, that first study we talked about. So the purpose of this study was, again, to evaluate the relationships between procedures, these injections, surgeries, and imaging, and care patterns in back pain episodes. So we looked at 3 different care patterns of spinal manipulation. So we looked at patients who initiated care with spinal manipulation, who were exposed to spinal manipulation, but later in treatment. So meaning they saw other providers first, and then they saw chiropractors later. And then we had a no manipulation comparison group. And then, you know, we wanted to look at the associations between which of these types of care patterns the patients were exposed to, and how does that influence their exposure to imaging studies, injection procedures, and surgery. So we found results that were similar to the first study, right? Which is, if we initiate care with spinal manipulation for back pain, we see about a 30% decrease in the risk of imaging studies, injection procedures, and back surgery compared to the control group, which is the no spinal manipulation group. So to me, that wasn't so surprising based on everything we've discussed so far. What was a little bit surprising is the group who delayed spinal manipulation exposure actually increased their risk of escalation of care to, you know, a significant degree. So it makes you question the timing of exposure to spinal manipulation. And if we are able to get these patients in our offices as the first provider, it's very clear from, at least from this study, and there's plenty of other studies that I cite in that paper that show that initial conservative care has a significant protective effect against treatment escalation. What has not been very well studied is these patients who seek other care and then end up in the chiropractor's office because the other care was not successful, right? So these are what we might consider to be higher risk patients because they've tried other things that haven't worked. And we also have a variable in this data set, which is a risk score variable. And we can look at the risk score across these three different care patterns. And we see that the risk score is much higher in these patients in the delayed manipulation group. So what that indicates to me is that they have higher comorbidities. They're more medically complex. And these are the types of patients generally that start treatment with a primary care doctor because they often are already seeing either a primary care or another specialist because they have other comorbidities. And they develop back pain and they have a relationship with a primary care doc, so they see them first. So there's a substantial literature on evaluating the medical complexity of patients who seek chiropractic care versus medical management, for example. And it's fairly clear that patients who seek chiropractic care, for the most part, are less medically complex. They have generally lower number of comorbidities. They have lower average pain levels, and they have lower levels of disability on a variety of different outcome measures. So we have to account for that when we're evaluating the comparison, right, between provider types, because we're not necessarily comparing apples to apples here. So the way we evaluate for that is by using these risk scores and other variables in regression models, and we try to balance them out and we account for them, which we can't we can't do completely. This is not a randomized trial, but there are analytical methods to try to account for this baseline difference in patient characteristics.
Yeah, I'm just struck by how all of these papers are so cohesive with each other. Just hearing you discuss all of them, in reading in this particular paper, tables 2 and 3, if chiropractors or others really want to dig into it, it's very clear to see that the initial SMT group had significantly reduced risk for all of these escalation issues. And then, so I'm glad you also talked through the group that delayed SMT, because that was my major question of, what's going on in this group? What were some of the other factors? Comorbidities, I think explains that quite nicely, as well as seeing medical providers first. And we've had, much discussion about that already in this conversation. So fantastic. I think these are just awesome papers. And before I let you go, though, I do want to, I ask everybody, as you know, Dr. Anderson, about if you can provide any advice to chiropractors or students who wish ultimately to become scientists and researchers, hopefully within our profession. If you could offer anything at this point.
Yeah, a common theme here that I think I've mentioned a few times is that don't be afraid to reach out to chiropractic researchers who are doing research that you are drawn to or impressed with, or that kind of align with your interests, because it's a relatively small group of us, right? And we understand the challenges of getting through, a PhD program, or even just the process of conducting a research study. And those people who are early career haven't had a lot of those experiences yet, and it can be overwhelming, right? To start down this path without having a group of mentors that you can go to and get advice from. And that's really the approach that I took, right? And I remember, Dean, that I reached out to you quite a few years ago when I first started my PhD program. And
Absolutely.
I did the same thing with 5 or 6 other DC PhDs who I really admire and who are doing great work. And it might not lead to anything substantial as far as research collaborations, but there's always advice that you can get from people who have been down this path before you. So my advice is to reach out, contact other chiropractic researchers who you admire or who you're interested in knowing more about. Form a network of mentors, whether they're officially chiropractic researchers or not, who can help you kind of navigate this path, right? And this is the approach that I took, and it has paid off in spades. I'm telling you that the opportunities that I've had, 2 of the papers that we talked about today, the R15 grant that was successfully funded, all of those things began by a simple email or a phone call, reaching out to someone with a question or advice or something along those lines. And a year or 2 years or 6 months down the line, these people have opportunities that they're looking for help with, and you never know what that is going to lead to. So broaden your group of mentors as to include as many people as possible. And I think really that's the best advice I can give.
Yeah, well, that's great. It's excellent. And as well as me, I mean, there's just no better feeling than being able to contribute in a meaningful way to the profession when it comes to research.
Yes.
So, yeah. Well, hey, Dr. Anderson, this has been a great discussion that we've had. I wonder if you have any last comments, or did I extract everything from you already?
Boy, I think we covered it. I want to again thank you for reaching out to me. Like I said, I've always thought that I might at some point end up speaking with you on the podcast, but I wasn't sure when that would happen. And it's really an honor to talk with you and get my story out there and get more people exposed to the research. So it's a great thing that you're doing here, and keep it up.
Well, I thank you for that, and honestly, is my pleasure. I just love to hear about the latest in chiropractic research. I mean, we're progressing. There's absolutely no doubt. I mean, 10, 15, 20 years ago, you'd have to wait a month or 2 months for a really significant paper to come out. At least that's what it seemed. I'm probably mischaracterizing that, but you know what I mean. And so now it's just constant. It's a barrage of, it's super difficult to keep up. But this is one of the best ways that I've found, at least for myself, to get to the individual researchers, to explore the themes that they've been covering, and try to get this information out. And I hope and I know that many chiropractors have, pursued careers in research. And so for that, I'm very grateful. And I just wish, everybody the best success, whether they're in practice or they're considering, again, pursuing a career in research, which I absolutely hope they do, because we need as much as we can possibly get to make these advances, like we talked about today, to fully be into Medicare and to these sorts of things. But my bottom line, I think like yours, I just wish more people took advantage of chiropractic care.
Yes.
So
I mean, despite it being, likely the most utilized conservative care kind of branch, it's still dramatically underutilized. Yeah, I agree.
Yeah, totally.
So, yeah, I just want to, I guess, end by offering myself as a resource. Even though I consider myself still to be early career, anyone who is kind of even earlier than myself, or has any questions or concerns about any of the grant opportunities or the loan repayment program or anything that we talked about today, I want to be a resource for people who are coming in kind of the next generation. So
well, that's
don't
great.
hesitate to reach out.
Yeah, that's great and very kind. And I have found, as you mentioned, that it's a fairly tight knit community that we have. There aren't that many chiropractic researchers. We need more, and almost everybody that I've reached out to has is the same. For the most part, everybody wants to advance this agenda of getting more research, and so people are eager and I think very, very willing. So please take advantage of that if you're considering this. So again, Dr. Anderson, what a great conversation. I'd love to have you back on after you get some more publications out there. We can sit down again at some point. It'd be awesome.
Absolutely, it would be great. I would love to.
Cool. Well, thank you so much.
Thank you, Dean.